Hi, I'm Corey Hudson. I'm director of the Emergency Medicine's Primary Care Sports Medicine program at Georgetown and MedStar. And as part of our Sideline Boot Camp series, we're going to go through care of the helmeted athlete. One of the things we see as we're providing sports medicine coverage is that occasionally we come across the injured athlete in sporting events who is in a helmeted sport like football or hockey or lacrosse. And we find that the helmet and equipment can sometimes seem like a barrier to the appropriate care and the assessment of the injured athlete. So we're going to talk about how we handle that. First thing we're going to talk about is sort of the anatomy of the equipment itself. So talking about the helmet first. So helmets, by and large, are very similar. This one's a football helmet, obviously, and for American football, talking about a polycarbonate outside shell, kind of a plastic shell that has padding inside. Usually that's high-density foam padding. And then there's often an air bladder as well. The air bladder is controlled by a little pump with a needle on it that looks very much like a blood pressure cuff pump. Often your equipment manager will have that in their pocket. Sometimes the athletic trainer will have an extra. If you need to rapidly deflate the helmet to help get it off in a pinch, you either use that, or if you need to, like an 18 gauge needle in the top of one of those holes on top of the helmet will get that out. If you use the needle, you may actually damage it in such a way that it can't be used again. But again, in an emergency, that may not be a crisis. There are often high-density foam cheek pads that you see here on the sides that can be snapped in and out. We'll talk about that later, how we can use those, get them out to help get the helmet off in a pinch, in a hurry. A chin strap that snaps on the sides, often in two places on each side at the temple, and again down by the jaw, down by the mandible, and then a face mask, and we'll talk a little bit more about the face mask. Most of our athletes should be wearing a mouth guard that may be custom fit or maybe kind of a Boylan bite, kind of semi-fitted mouth guard. They may alter that a little bit by cutting it down just to barely fit inside their mouth. It may be dangling from the face mask, it may be dangling from their mouth, and they may barely be wearing it at all, depending on how much they have decided to comply with its use. So the face mask itself comes in lots of sizes and shapes, from a kicker who may have really just a perfunctory face mask, which just barely comes around in front of the mouth, to a lineman who has a really kind of beefy face mask that's going to prevent fingers from going into their nose and into their eyes. They may wear a plastic shield in front of their eyes to protect their eyes. It may be tinted to help with sun glare. Usually these face masks are made out of, again, a polycarbonate resin or plastic. The old-fashioned style were made out of metal that was then coated in kind of a rubberized material. They're attached to the shell, usually in at least 4 points, sometimes in 6, but usually 2 down by the jaw, 2 more up by the temples, and sometimes by 1 or more up at the forehead. Those clips are usually attached either by a screw, like this one. This is a Phillips head screw here, or sometimes by these kind of spring-loaded clips here. We're going to talk about both of those. These screw type clips are attached by a sort of U-shaped rubberized plastic clip, which can be cut. These spring-loaded clips, the plastic is much harder, but the spring itself can come apart, and we can use that to our advantage if we want to either remove the face mask entirely, just lift it up by taking off all the clips, or we can leave the 2 intact at the forehead and hinge the face mask up this way. The whole key is that we just want to be able to get access to the airway. We really don't need to remove the face mask entirely. We just want to lift it up so that we can get airway access. So if we're going to try to get in, the question is, how do we do this while minimizing movement of the cervical spine? So assuming that we may have a cervical spine injury, we want to minimize the torque and force on the cervical spine. In this case, you see the athletic trainer, we presume, is here at the head, and they're using their knees to stabilize the cervical spine. It's not the best way to do it. We're going to talk about some other ways to do this. Better would be to have one person maintaining cervical spine alignment with their hands and have a second person coming in to take the face mask off. That could be an equipment manager, that could be a second rescuer. You see here in the left-hand side, they're using a screwdriver, and actually that has been shown to be the method that uses the least amount of force and torque on the cervical spine, is an electric or battery-powered screwdriver. And so that should be plan A for these ones that have a Phillips head screw. If you can, make sure that your equipment team has reconditioned the helmets frequently. They're switching out those screws so that they're not stripped, they're not rusted. And you want to have several battery-powered screwdrivers. You want to make sure you've got backup batteries. You want to have a couple manual screwdrivers as a backup. And then you want to have a backup method. You want to have a backup and a backup to your backup. And so you have these cutting tools. In the middle here, you see several that have been used through the years, everything from pruning shears that would use to trim a rose bush, kind you can buy at Home Depot or Lowe's, to tools called Trainer's Angels, which have been devised to specifically cut through those plastic clips. A tool on the left called an FM extractor, again, designed specifically to cut through that plastic clip. It kind of holds onto the clip on one side and slices through it from the other direction. And then some other cutting devices. So again, these are for those clips that have a screw, that rubberized plastic kind of clip. We're going to cut a 1 centimeter strip out of that rubberized plastic, lift that piece out, and then we can lift the face mask out from in between. These newer helmets made by Rydell have this harder plastic clip, and then this metal device in the middle. It kind of looks like a donut. In the center of that is a small little button that can be depressed. There's a special tool again for this. Your athletic trainer and your equipment staff should have that device. But in a pinch, you could use anything, a ballpoint pen or any sharp, hard device to kind of get in there and push down that center. And the whole thing is spring loaded. That metal piece will kind of come apart, and then the clip comes apart, and you can kind of unfold the clip, and then the face mask will come out of the inside. Once you do that, you can take off the entire face mask here. And this one with no clips at the forehead, you'll just be able to remove the whole face mask. Right? So then the face mask is out of the way. Then we get to shoulder pads, and we ask ourselves, if I need access to the chest, and if I need to get my hands on the chest to do CPR, if I need to get in there to put defibrillator pads on, how am I going to do that? Right? First thing to remember is we don't need to get all of the shoulder pads off. We don't need to get the patient to a bare chest. We really just need to be able to get our hands to the sternum. We need to be able to get those AED pads in place. So really, we just need to be able to gain access to just a little bit of the anterior chest, or the anterior and the posterior chest if you want to use that placement for your AED pads. The easiest way to do this is with a pair of trauma shears. You're going to cut the jersey. You're going to cut whatever's under the jersey. You're going to cut through the shirt. And all football shoulder pads will have some sort of fastening device, usually laces, or sometimes an elastic strap or a soft plastic strap right up the midline here in the front. And you can just cut straight through that with your trauma shears, and these pads will flap out of the way. You can get them, kind of clamshell them open in the front. Again, cut through the undershirt if there is one, and get the hands on the chest for CPR, or get those AED pads in place. Again, don't worry about getting the pads off entirely. If you're worried about an athlete who doesn't have a pulse, just go ahead and start CPR, get those AED pads on. If the athlete has one of these add-ons in place, like a neck roll or a rib vest, a cowboy collar, or a flak jacket, again, these all connect right in the midline. So don't worry about getting them off or getting them entirely out of the way. Cut up the midline, unfasten in the midline, go straight up and just get to the chest. There's been a lot of debate through the years about whether or not we should take the helmet and pads off or whether we should leave them on. And I think the real question comes down to what is the injury and what are we treating? But with American football in particular, we should remind ourselves that the equipment has been designed to maintain neutral cervical spine alignment when both the helmet and the shoulder pads are left in place. So if we leave the pads on and take the helmet off, we're going to see the supine athlete drop their neck back into extension. If we leave the pads, or we take the pads off, but leave the helmet on, we're going to see the chin pushed forwards into flexion as that occiput's lifted up and with the back of the helmet on. So with both on, we keep a nice neutral spine, and there's something to be gained from that, right? It's nice to have that, especially if we can get that face mask off. We've maintained neutral spine alignment. And if we're worried about a spinal injury, maybe that spinal alignment is a good place to be as we're moving forwards. So the traditional teaching has been that unless the athlete's life is in imminent danger, maybe we should keep those pad and helmet on, and we should transport them to the hospital with those there, again, with the face mask removed to access the airway. If the athlete needs CPR or defibrillation, the chest can be exposed, as we discussed, and we can gain chest access that way. But there's been some conflict over the years, and that's that the athletic trainers were taught to leave the helmet on, but EMTs have long been taught to take helmets off, and that probably stems from the fact that in BTLS and ATLS, there have been guidelines for removing motorcycle helmets, and that probably comes from the fact that motorcycle helmets do not have removable face masks, and motorcyclists are not typically wearing shoulder pads, so motorcycle helmets will, again, push that neck into flexion, and with no face mask removal, EMTs feel like they need to get that motorcycle helmet off so that they can gain airway access and maintain neutral spine alignment. That's not wrong for that situation, but they can't segue that information into athletes. And because they're more likely to see injured motorcyclists than they are to see an injured lacrosse player or football player, they say a helmet's a helmet's a helmet. Many physicians on the sideline, especially physician parents, are not comfortable assessing an injured athlete and equipment, right? They are not, it wasn't taught when they were in medical school. So they're much more comfortable assessing the patient who's wearing shorts and a t-shirt than they are the athlete who's wearing a helmet and shoulder pads. So they would like to get that equipment off so that they can assess a patient in their natural environment. And so they'd rather have that equipment off. And physicians working in the emergency department are also not taught routinely how to take this equipment off. And so for a long time, we've been sending athletes to the hospital in all of this equipment. And once they got to the hospital, we were being treated by emergency department staff who weren't fully trained in how to get that equipment off safely either. Any of you who've spent any time in the trauma bay sort of are familiar with the strip 'em and flip 'em mentality, and can imagine what would happen with all that gear going flying every which way unless you sent an athletic trainer or somebody who was really well versed in how to get that equipment off, and you had a trauma team who was willing to listen to that person. It was going to be a little bit of a conflict when that athlete got to the hospital and you needed to get that equipment off. So in 2008, an inter-association task force convened to define the appropriate care of the spine injured athlete. That task force included representatives from 25 professional organizations, including the Neurosurgeons Association and the Orthopedics Association, the NATA, the NCAA, ACSM, multiple organizations representing primary care, emergency medicine, orthopedics, neurosurgery, athletics organizations, you name it. Everybody got together. And they came up with some really great guidelines on how to manage the spine injured athlete. In the late teens, and ultimately the revision came out in 2020, they came together trying to come up with a consensus and revision guidelines. And they had some really difficult time coming up with consensus and ultimately couldn't get a consensus with all of the same organizations together. And there were a couple of problems there. And part of that is there was a dispute over this equipment removal question about whether we should leave the equipment in place or whether we should remove the equipment. We're going to come back to that in a second. And there was also a big change in EMS attitudes towards spinal immobilization, or what we now call spinal motion control. And as many of you are aware, EMS has kind of done away with backboards for the routine care of patients who have had trip and falls or motor vehicle accidents. Most patients with neck and back pain or suspected spinal injuries in the field are no longer treated with long spine boards. And that's because the incidence of cervical spine and thoracic and lumbar spine injuries amongst all comers in EMS is actually quite low. The problem is that the pretest probability for cervical spine injuries in our patient population is actually much higher. We kind of pre-screen those patients for them. So this is not like every ground level fall and every fender bender that the EMTs see out in the world, right? The pretest probability amongst our patients is actually much higher because we are already selecting for the patients who have midline tenderness, weakness, numbness, or tingling, who have other deficits. We're only calling EMS if we find something that has a pretty significant suspicion for an injury. And so we really do want to still use some sort of spinal motion control in these situations. So we had to come up with some sort of plan to reconcile these things. So this is what I'm up with. Number one, any athlete who's suspected of having a spinal injury should be managed as though they do have an injury, which means we should still assess the ABCs, which, as you know, we've now switched to the CABs, circulation first, airway, breathing, and a rapid evaluation of neurologic status. We don't want to move that athlete unless it's necessary for airway management. So if they're prone and we can't assess their airway, you do roll them over so that we can assess their airway. But otherwise, if they're awake and talking and have an adequate patent airway, we want to leave them prone while we do that initial neuro assessment. And then we want to carefully, when we have enough rescuers present, then roll them. We're not going to quickly try to stand them up and usher them over to the bench, right? Potentially making a cervical spine injury worse. We're going to activate EMS early, which means that in a game situation, we're going to call EMS out on the field. We should have rehearsed our drills with them so that they know what we're doing. In a practice situation, we want to go ahead and call for EMS sooner rather than later. The last thing you want to do is have your patient all packaged and ready to go, and then be twiddling your thumbs waiting for the ambulance to get there. Last two are important. And the number one is, with an adequate number of trained rescuers, equipment may be removed at the discretion of the medical team. This was kind of a compromise, right? And this is where we say that if the medical team agrees, and that means the athletic trainer or the team physician or whoever's in charge on site decides they think they want to remove the equipment before they transport, they can do so, and that's okay. And they acknowledge in the statement that it takes a lot of trained rescuers to do this, to do it well, to do it properly. And we're going to talk about that a little bit, and we're going to practice it later in the hands-on session. And then many, many times, and if you read the statement, you'll see there's lots of times where they say over and over again, maintaining a patent airway and cervical spinal alignment are paramount, right? So no matter what we do, we want to make sure our airway is maintained and that we're maintaining cervical spine alignment. So all else aside, those are our real keys here. So when we're managing the downed athlete, if we suspect a spine injury and the athlete is prone, we're going to assess that airway, breathing, and circulation. We're going to assess for neurologic deficits. We're going to stabilize the cervical spine. We're going to make sure we check our hand position, right? We don't want to get tangled up. And when we do the hands-on station, we're going to practice that. We're going to roll the athlete using a long inline roll, trying to maintain that neutral alignment of the spine. And we're going to roll them directly onto a long spine board or another appropriate extrication device, whether that is vacuum mattress, whether that is any one of a number of other, a scoop stretcher. There's several appropriate and acceptable extrication devices, but the most commonly used one is going to be a long spine board. We're going to remove that face mask. We're going to secure the athlete to the board or the extrication device, often without a cervical collar, and that's because a cervical collar does not fit well if we're going to leave those shoulder pads in place. So we're going to use another way to secure the head to the board. We're going to recheck the airway, breathing, circulation, and neuro deficits, especially that neuro, after we just moved the athlete, and then we'll go ahead with transport. Sometimes we'll decide to get to the ambulance and then we'll take them off the board. We'll take the equipment off, especially if it's going to be a long transport, because there is some data which suggests that leaving an athlete or any patient on a long spine board for prolonged transport may increase the risk of things like pain, decubitus ulcers, difficulty breathing, etc. So if you are 3 counties away in a 40-minute transport from the hospital, you may want to think about transporting that patient just on the EMS stretcher and not on the long board. If you're in the city and it's going to be 9 blocks to the hospital, it may be most appropriate to just leave them on the board until you get there. In your supine athlete, this is going to be very similar. You're going to do that ABCs and neurocheck. You're going to stabilize the spine. We're going to talk about how we put the hands on the traps and use the forearms to squeeze. We're going to remove the face mask. We'll talk about how we do this 6 or 8 person lift to get them onto the spine rather than a roll. Again, we're going to strap them down to hold them to the board securely, and we're going to recheck the ABCs and neurocheck. When we're taking that face mask off and managing the airway, the key again, we want to make sure it's removed before we transport. There's nothing worse than thinking that you've sent an athlete on their way to the hospital with maybe tenuous respiratory status and that face mask in place, and somewhere between point A and point B, the respiratory status declines and the airway is not secure. So regardless of the current respiratory status, that face mask is removed so the airway access is absolutely patent clear and able to be intervened upon if needed. Everyone involved in the pre-hospital management should have the tools necessary to remove the face mask, which means there needs to be a plan A, a plan B, a plan C, a plan D. There need to be multiple methods. There need to be backups of backups. There need to be extra batteries. There need to be extra screwdrivers. You need to have extra cutting tools. Everyone involved on the sideline needs to be familiar with the appropriate steps, which means everyone from the equipment people to the athletic trainers to EMS to the physicians. Everyone needs to know their role. They need to know what the steps are so that nobody's getting in the way, nobody's rushing the steps, nobody's stepping on anybody else's toes. And we want to define and delineate those roles. We need to pre-plan for those potential and serious catastrophic injuries, which we call emergency action planning. And we want to have defined roles so that when something happens, we know who's going to be holding C-spine, who's going to be managing the face mask, who's going to be doing the lift, who's going to be doing the board, who's going to be doing the straps. Nobody's getting in the way when we need to. We'll be going through this in the hands-on station, but I want to make sure everybody talks about the steps here. Knowing that a properly fit helmet can hold the head securely, but doesn't have to be removed prior to transport. The helmet should be removed if it's loosely fit, if it's not holding the head securely, if it's not immobilizing it well, or if the face mask, once removed, is still the helmet is still blocking the airway, or if the helmet was kind of left askew, if it gets tilted, or if it's once during the injury itself is kind of wonky and off center, or if the helmet itself is preventing immobilization in an appropriate position. Face mask removal, we talked about briefly. This is an example of cutting that loop strap. So we're cutting little slits here. We're going to lift out that little centerpiece in the plastic right here. You're going to cut one cut here, move over about a centimeter, make one cut here, take that little piece of plastic out, then you can lift the strap or the face mask right out. Those specialized pruning shears cut through the straps, or you can use a screwdriver as we discussed earlier. When we're taking off the shoulder pads and the other equipment, it takes at least 4 trained providers, more if the patient's large. If they're talking about a 330-pound offensive lineman, plan to have 6 or 8 people. And that may mean we're enlisting our strength and conditioning coaches. We're going to have our offensive line coaches help. We're going to have other people help us with our lift. And we need people who've trained this with us, or will be able to follow directions when we say, do this, now step here, lift here. Only those most trained providers should be at the head. The athletic trainer or team physician should be the one holding the C-spine. Only those who've managed the face mask and helmet should be managing the face mask and helmet. The least trained rescuers should be the ones who are lift assist. Each step should be reviewed and discussed. Again, we're in a hurry, but we're not rushing. So we have time to say our next step will be, everyone's going to put the arms underneath, we're going to cross them, and we're going to lift. Does anybody have any questions? All right, let's put our arms underneath. All right, I'm going to ask, is anybody not ready? And you're going to make eye contact with anybody. I like saying, is anybody not ready? Because if you say, is everybody ready, and you hear a chorus of yeses, you're not sure if there's a voice you didn't hear because nobody said no, right? So is anybody not ready? Hearing silence, you know that we're okay to move forward. When we want to take that helmet off, if you are going to take the helmet off, it's best to cut the chin strap rather than unsnapping it. Unsnapping it's going to put a lot of torque and force on the head as you're pulling those snaps out. You want to get the cheek pads out because it's going to give you a little bit of extra space. So if you're going to do that, you can get a tongue blade or the flat edge of a pair of trauma shears in there and twist very gently. This will cause a little bit of torque, but if you twist very gently, you should be able to pop the snaps there on each side to get that cheek pad out. One person gets their hands up underneath the jaw and holds C-spine from the front. The other person opens up the ears, makes them wide, and then tilts towards the forehead, and then pulls up towards the crown of the head. Be careful when you do that. The person who's holding at the chin needs to be very careful because the head will drop into extension. You really need to be prepared for that, right? So here shows as you widen up the ears, widen up the helmet towards the ears, tilt it towards the forehead a little bit, and then pull it straight off. We talked about cutting the jersey, cutting the shoulder pads. Again, if we flap them this way and we're ready to do that, we could do this about the same time. That person is still holding here at the jaw, right? The person who's now taken the helmet off can continue and just slide those shoulder pads right out from the shoulder blade straight up over the head. The torso is just off the floor, just a couple of degrees. We can lay back flat. The person who's now at the head can take back over cervical spine control. At that point, you could now apply a cervical collar because now the pads are out of the way. Know that other helmets, other pads, other sports are a little bit different. So hockey and lacrosse are not made to stay in neutral alignment. As you see here, the back half of an ice hockey helmet is very flat. The pads are much bigger, so they're not going to keep you in alignment. Opposite is true for a lacrosse helmet, has a whole lot of occiput, but the pads are tiny. Goalie equipment is very different in both sports. So ice hockey goalies have very, very molded two-piece helmets. The occiput is actually molded to their head, and then it is actually clipped onto the front. the front of the helmet and the mask and the top are one piece, and then they're actually clipped on here. You could cut through those elastic straps if you needed to. The occiput's so molded it can stay in place. Both hockey and lacrosse pads have a very built up hard shell over the anterior portion of the chest, so you cannot cut up the anterior portion of the sternum if you need access to the chest because of the risk of very hard, fast flying objects, which could cause commotio cordis in both sports. They have very firm chest plates. So in both cases, their pads have access points at the axilla. So if you need to cut in here, you're actually going to cut at the mid-axillary line and here at the anterior axillary line, and their pads are going to flap open more like a doorway from one side. So just look before you cut and know you're not going to be able to cut through a chest plate in these sports. So in review, when you've got these athletes, you're going to look at your ABCs, you're going to assess for possible head and neck injury, leave the helmet and shoulder pads on if possible, and if a neutral spinal alignment is maintained. You're going to remove the face mask prior to transport, even if the airway is looking fine at the time. You want to remove it regardless of current respiratory status. Spine board immobilization or spinal motion control or another extrication or mobilization device with or without a C-collar if you're going to transport. When you're removing the helmet and shoulder pads, you want to use several trained providers. And you want to think about removing both the helmet and shoulder pads simultaneously to maintain neutral spinal alignment throughout. And again, we're going to review all of these things in a hands-on session so you can practice. And the last thing I'll throw in is remember these are just guidelines. Your mileage may vary. There are going to be situations in which you say, this is exactly how we practice it. And in this situation, it's different because. And so sometimes you have to make adjustments on the fly. So use what you've learned today, use these guidelines and practice so that you're comfortable knowing when this works, when it's perfect, and when you may need to deviate from the plan. Thanks so much, and we look forward to rehearsing with you.